All right. Scott,
Welcome.
We're
hey,
here.
How's it going, Britt?
Okay, so we're here for Urgent Care Grand Rounds. Super excited about tonight's lineup. Speaking of our lineup, who do we have here with us tonight?
We have an incredible show for y'all tonight. Here's our faculty with us here in the studio. Who do we have, Britt?
We have the famous Dr. Mel Herbert.
Woo!
We've got the Stewart. We've got Greg Moran, Sean Nort, and Jesse Werner.
And unfortunately, we can't have with us tonight because they're too busy recording more great episodes of the UC Max podcast. But our podcast hosts, Gita Pensa, Mike Weinstock, they'll be joining us virtually with some pre-recorded clips, so look out for them throughout the evening. Speaking of the podcast, Britt, just dropped this month. We're really excited about it. There's one segment in particular that really spoke to me, this missed appendicitis case. I had a mentor once tell me that you're not truly christened as a emergency medicine or urgent care provider until you've missed a case of appendicitis.
Oh, I was christened many moons ago then. It's not always that straightforward, right?
It really isn't.
You want the classic, like, oh, periumbilical, now it's right lower quadrant. But, I mean, in pregnancy, that can be complicated. Actually, I had a recent case just yesterday. This lady came in, she had left flank pain, it was colicky, it radiated down to her left groin. We're like, cool, first time stone, we'll scan her, we're good. Acute appendicitis.
Of course, wrong side, different history, different diagnosis.
Didn't read the textbook.
That's why I missed it. Great segment, one of my favorites of this month. We want to remind you guys, too, who are joining us on YouTube, obviously, to subscribe down in the goobly-goo below so you don't miss any of the other grand rounds that we're putting out, any important messages from us. And we're going to pick a winner of one of our new subscribers from tonight to get some sweet AirPod Pro Max 5, 7s, whatever they have now.
I really need another pair. I
You
feel
should
like I
subscribe.
should subscribe.
Yeah, you subscribe. It counts for us, too. But before we even get to that, we'll also remind you to throw into the chat any questions you have. We're going to be monitoring out the whole time. We're going to be throwing some polls in there. Make sure we keep this nice and interactive, and you get the things that you need to learn about urgent care. So, without further ado, Britt, we're going to our next segment. What do we got coming up?
To start our grand rounds off tonight, we have images of the evening.
Oh, sorry. All right, I'm Jesse Werner. Thank you so much for being here tonight, and I am presenting images of the evening. Okay, so I'm going to start with a case. This is a case for you. So this is a young woman. She's an officer. She is running after an assailant. She trips on the curb. She plantar flexes her foot. Maybe there's a little axial loading, but she has severe foot pain. And she comes into the ED. She cannot walk. We take off her shoe, we take off her sock, and we notice that there's some ecchymosis to the plantar aspect of her foot, okay? So we get some images, of course. We get an x-ray, and this is what we see, okay? What do you see? What are you noticing on this x-ray? What do you think?
Well, there's a few things. Well, of course, mechanism, right? So you think about this mechanism and...
what do you think about this mechanism, actually, Sean? Because what I think about it was, it's more than just. I'm thinking it's not like obviously a car accident in terms of the energy.
That's true.
But it's a police officer in pursuit. I mean, I'm thinking there's probably a lot. She's probably going real fast. She's probably got a lot of weight, you know, that's weighting her, like all her stuff, and you know, and like to me, I'm thinking it could be a serious, like it could be a major injury. It's probably quite a bit of energy. That's sort of how I'm thinking about it.
I agree with you. And then she's got the ecchymosis. She can't weight bear. So
And
that's
what is
already
the-
telling us. Like,
right, yeah, for sure. She can't weight bear. And the ecchymosis to me means, I mean, it doesn't mean there's a fracture, but it means something's ripped.
Yeah.
You know,
That's
something
right.
is torn, something's bleeding.
Right.
So that's another thing, you know, towards a little more serious.
Totally.
so we're going in with a high concern, right,
Absolutely.
based on there. And then looking at the x-ray, and often when I look at x-rays, I try to stand back, and it just doesn't look right. Right off the bat, you say it doesn't look, things are a little bit wider
Yes.
than usual, right? I'm just looking at it and I'm saying, hey, things
Where's
are...
the wideness?
And
I
the
guess,
wideness
yeah.
is at the midfoot. So anytime I have an injury, of course I palpate everything, but I'd be concentrating very much on that midfoot
And it
for
looks
this
like
person.
it looks like the first and the second ray are further apart than they usually are. There's a gap there.
That's right.
Yeah.
You're totally right. You're totally right. And so we initially got normal x-rays of this foot, and there was really nothing obvious. I mean, there's not a fracture on this x-ray. So we had to get a different kind of x-ray,
Yeah, some stress.
a little bit of
So you
weight
got a little
bearing,
weight bearing.
and that really showed us this separation between the first and second toe
And
there.
hurt the patient, and the patient
And
was
it
probably
did. She
not
hated
happy.
it.
You hear a yelp from the radiology
Exactly.
suite, right? Yeah.
That's it.
She totally
Yeah.
hated it. So what is this diagnosis that what's it called?
So this is a Lisfranc.
Yes,
if I'm
it is.
pronouncing that, you're the Canadian,
No,
but the
listen,
Lisfranc
yeah.
injury right
That's-
here.
You sound so good.
Well,
I'm just going to say very American, Liz
There you
Frank.
go. There
Liz
you go.
Frank
Liz
is the
Frank.
American.
And the key things here, you're totally right. We've got some widening, especially between the first and second metatarsal. And when you're looking at this kind of x-ray, you certainly want to start with the fifth metatarsal, moving to the second metatarsal, and you're really looking at the first and second, the medial and the middle cuboid. And you're seeing how this middle cuboid lines up with the second metatarsal. Importantly, does the medial aspect of the second metatarsal line up with the medial aspect of the middle cuboid? And actually, it's not bad here. So this is kind of subtle. It's really the widening that you notice. You're totally right. This is a Liz Frank injury, or Liz Frank. Beautiful. What are some things that we need to think about with this injury? Because it's totally devastating.
Well, just before we move on from the radiology, I mean, there are like 5 different radiographic findings. I have to look them up every time. And this is one not to be, reach out to your friendly radiologist or a colleague and say, hey, what do you think? Because it's an easy to miss fracture.
It is.
And because there are the
Yeah,
consequences.
like because you don't see sometimes you see a little chip, you see a little fleck there.
Yeah.
That's sort of a hint that it's there. But often you really have to look at it carefully and make those lines. And this is a thing, is that let's talk from an urgent care point of view here. You're really busy. And the key take-home message here is probably this is a very dramatic looking, swollen, bleeding injury where it's like, wow, this is probably a little more than, and she probably knows that, the officer.
Yeah.
This is probably a little more than when I sprained my ankle before, like I can't walk and this is worse. And so it's the suspicion really that's the issue here, more than the x-ray, because I think we all have to kind of go back and check, oh yeah, this doesn't look right, but let's check the actual criteria, have a radiologist look at it. It's the suspicion that's important here.
Very
I think
good.
That's totally right too, Stuart. And like when you have somebody who has that axial loading mechanism, and I'm palpating and they have that midfoot pain. For me, I know you were joking that the pain for causing the weight-bearing x-rays, of course, it's uncomfortable, but that's why I try to get the 2 feet on the one film, because sometimes this very small amount of difference in separation can be masked by the patient not really putting their full weight onto the film. So at least if you have both, you can encourage them to try to put both feet down if that's the only imaging modality you have in the urgent care, but you can compare. It's a free shot, both sides, to see that subtle difference. If you have a high enough index of suspicion, say it's probably an injury.
Thank you, Scott. That's such a good point. Comparison films, if there's any doubt, can be very helpful. And I do want to point out a difference. I think this is confusing between the Liz Frank joint and the Liz Frank ligament. So the joint itself, as shown here in this image, is actually where the tarsals and the metatarsals articulate together. That is the joint. That is what creates stability of the midfoot. And of course, this injury causes midfoot instability, a lot of pain. It's a very serious injury. It is a surgical repair and non-weight bearing. These patients are non-weight bearing. They need emergent ortho follow-up. But the Liz Frank ligament is important to talk about because it is actually a ligament that is between the medial cuboid, so this first cuboid, and the second metatarsal. It all comes back to the second metatarsal. It's either the first or second cuboid we're talking about or the second metatarsal. But the ligament goes right here between the medial cuboid and the second metatarsal. And what's important there is that if there's ligamentous disruption, you might not see a fracture on the x-ray. You're just going to see that widening. Or you may see what you were talking about, Stuart, that flex sign, a little avulsion injury off the tip of this second metatarsal, and that is suggestive of a ligamentous injury.
Yeah, it's kind of like the tip of the iceberg. You see the little fleck and you know that there's massive soft tissue injury underneath it. Yeah.
Should we go to our next case? Did we hit everything?
I think we shall.
Okay, let's go to our next case. So, second case, this is just regular person walking down the street, but they are wearing clogs. And for anyone who's ever worn clogs before, they're actually not very stable, and it's really easy to sort of roll your ankle while you're walking. And so this young woman did just that. She everted her foot, she rolled her ankle, fell to the ground, had a pretty significant injury from that. And I'm going to show you this image. This is a little complicated, actually. It's a little more than I want to show you guys. But what are you noticing here?
That's one hell of a clog.
Yeah, she really fell. She really fell.
Well, when you look at this, of course, you see at the tibia, the distal tibia, you see that obvious fracture.
Right.
And again, being with radiology, but also with examination, I palpate the entire joint. From here, I'd go all the way the knee down, from the medial side, all the way across, palpate that foot, and go all the way back up, because if you look at that proximal fibula, you see that there's an injury right there.
And let me tell you what, on exam, this patient only complained of ankle pain. All she said was, my ankle hurts, I have ankle pain. And so it would be very easy, very common mistake, to just get ankle films. And when you get those ankle films, you see this devastating injury at the ankle. So tell me more about that. What made you think, maybe I need another image?
Well, probably I've been one of those people who've ordered just an ankle film and then had somebody come in. But really, no, I was taught as a student to palpate the entire for this injury, because this is, again, the challenge of saying it incorrectly. The Maximus, right? Fracture is
so
what
good.
we would be worried about here. And very often, I just pick that up because I will palpate. So the old orthopedic adage of the joint above and below, very often you don't need to do that, but this is one where that actually, with a good examination, would support making this
And Jesse, you
diagnosis.
should show us how the
Yes.
line of force goes up. So the forces are going up through that tibia, and then they go through the fibula, and what's in between them is the thing that connects those tibia and fibula together, and it's ripped apart.
Totally.
And you can see that widening of the syndosmosis. You can see that it's been torn there, and that is a very unstable injury. So it's, again, one of these things where you might just see the one crack. And by the way, that distal fibular fracture there doesn't have anything to do with the Mason
Little red
pattern.
herring.
And that might have actually been another injury. I don't know what's going on there. But sometimes, so you just see that one crack through the fibula, or for the tibia, and you're sort of tempted to say, oh, well, okay, there's an injury there, but it's not that bad. It is that bad, because it's ripped apart those two bones. And you know, you're going to need to address, that's a surgical consult there. And
Yeah.
so, you know, it's another one of those, doesn't look maybe that bad on the x-ray, but what's there is really substantial.
Another great point. This x-ray doesn't show it beautifully, but sometimes all you'll see is widening of the ankle mortise. And technically, the definition of a Mason is you have a medial malleolar fracture and or just the ligament, the medial ligament, that's called the deltoid ligament, is injured. And so you get widening of the ankle mortise, and that may be really all you see if it's just the ligament that's injured there. And you have to know to look, because as you said, the syndesmosis has been disrupted and it's then ripped apart the top of the fibula there. Now, why do we care about the top of the fibula? There's something important there.
Well, of course, the
It's got a little
perineal
nerve that runs
perineal nerve, and unless
Yeah.
you want to kind of flap your foot for the
Yeah.
rest of your
Yeah.
life,
Yeah.
right,
Yeah.
they'd be
Yeah. Foot
at
drop.
risk for
Yeah.
a foot drop
Yeah.
injury.
Which you might actually see. Like, I mean, they might present with that. You
Totally.
might actually see the foot drop. There's always controversy. Like, I was always taught to examine, you know, the knee completely to make sure you don't miss this and see if they're tender at that fibular head. But, you know, when people are in so much pain and it's so
true.
swollen, I've
true.
found that I've missed them because they were focused so much on the pain
yeah.
there that they didn't, you know,
That's
they just,
true.
I'm in pain. So I think it's maybe a good idea in a significant ankle injury to image the knee and
Yeah,
to make sure
I
that
would
the
agree with
fibula
that.
is okay all the way up to the top.
I think that's such a good point, because I literally had this case like 2 weeks ago.
Okay.
And it was seen by a previous provider, and they focused on the ankle. And they got the ankle and they saw the fracture and they're like, cool, done. And the guy still, even when I saw him, was complaining about such bad ankle pain, but his whole leg was so swollen. I was even thinking down the road, like, does he have a DVT now? And they just put him in this like little air splint, you know, like a little tiny, really not that stable air splint. And then when you palpated up his leg up towards his knee, he really had a lot of tenderness there. But he wasn't complaining about tenderness there. He's still focusing on the ankle pain. So you have to do that physical exam. And I think when the suspicion is high, just get the imaging.
Absolutely. And the last thing I'll say about it, as you alluded to, Britt, this is a long leg splint. This is a long-legged splint, not weight bearing, surgical. You're getting ortho involved. So let's move on to the next image. Of course, that was a mise en nu. How was that? Sound good?
I said, don't look at me.
That was really like French knife. That's pretty good.
Yeah.
So the next image is actually from Michael Weinstock, and you can see here, this is some bruising on the foot. He unfortunately couldn't be with us tonight, but we did catch up with him, and he's going to present our next clinical image.
Patients who come in with a ankle sprain are usually there because of a inversion ankle injury. And typically what we do in the urgent care is we palpate over those lateral ligaments. But we want to make sure that something else more serious isn't going on. And oftentimes with ankle injuries, the physical exam can be quite helpful. Thinking about palpating the proximal fifth metatarsal, thinking about potential fracture or fracture dislocation with a abnormal mortise that we would see on the x-ray, or a Lisfranc injury, or even the Mason-Nuz fracture that we talked about. However, the Achilles tendon, which is sort of a little bit further than we would see normally when we're just looking at the front part of the ankle, is something that can be missed. So here's how I do my ankle exam. First, I will palpate that area, because sometimes I can palpate a divot in that area. I'll also look for ecchymosis around the ankle, which can also happen with a strain, but sometimes with a Achilles tendon tear or rupture, we could see a significant amount of ecchymosis. I'll then also have the patient plantar flex against my hand. I'll check the strength, and I'll compare it to the other side. But then what I do is the Thompson test. And I do this the same way that just about everyone does, but I describe it just a little bit differently, and hopefully this can be helpful. I'll have the patient lay prone. I'll have them put their legs straight up in the air, and then I'll squeeze those Achilles tendon, actually calf muscles, and see if I get plantar flexion. So it's always been a little confusing to me when someone says, oh, well, it's a positive Thompson test. What does that mean? It's positive because they have a rupture, or it's positive because they actually had plantar flexion. So simply what I do is just describe what I'm seeing. And I say, I squeeze the calf muscle, the patient has plantar flexion, and so, therefore, this is consistent with an intact Achilles tendon. Or if they don't have plantar flexion, I say that's consistent with a Achilles tendon rupture or possibly tear. Although sometimes with the tear, you can still have some plantar flexion. That way, it leaves no room for error, no room for guessing.
Okay. So it's that time in the night when you can win some AirPods or be eligible to win some AirPods. So that was an Achilles tendon rupture. Now we are going to move on to a mystery image, and I'm going to present that to you. So here's the case, okay? A 7-year-old male was treated for presumptive strep throat with amoxicillin, and about a week later presented to urgent care with this rash. The question for you is, what infection did he actually have? That is the question. And the first person to answer correctly in the chat will win AirPods at the end of the night. Okay? That's mystery image. And now we are moving on to Expert Corner.
Expert's Corner.
With
All right, so here with me tonight for Expert Corner is Dr. Greg Moran. He is triple boarded in emergency medicine, internal medicine, and infectious disease. Are you working on another one that I don't know about?
I'm done.
Okay,
That's
he's done. He is an amazing musician. He's a bass player in our UCLA band, Gravely Disabled, appropriately named.
Yeah, quite.
And he is here with us tonight to talk about management of cellulitis and abscesses in the urgent care, something that we see all the time.
All the time.
It's very common, and really we're here to talk about the best management, the best care we can give these patients. So my first question for you, is there ever any need, any indication for culturing these wounds? Should we get a culture on these?
Very rarely. Generally, the types of cases that are going to be in an urgent care clinic where virtually always they're going to be outpatient treatment. I don't, for routine abscesses that we're going to drain, we're going to send home, I don't culture those. Because the bacteriology is pretty predictable. It's going to be Staph aureus, almost always. Mm-hmm. And whether it's MRSA or methicillin susceptible staph, we know that a big proportion of them, and in several studies showing it's more than half now in most places, are going to be MRSA. We're going to give them empiric coverage that's going to include MRSA. So I don't routinely do it. You know, maybe if they've failed treatment, if they're bouncing back multiple times, or if they've had a history of some weird, unusual bug or something, but that would be the rare, rare exception. I do it if they're bad enough to be admitted, if they've got, a big serious infection, necrotizing infection, something like that. But in an urgent care, you're going to be transferring those anyway. So
it doesn't sound like the culture ever really changes your management.
It would be very rare that it would ever change your management. And mostly by the time you would get it back, if you do a good drainage and they're on antibiotics, which we'll talk about in a little bit, I suspect, then they're going to do fine. So it's not routinely necessary to do so.
Okay. So now let's just go to like a simple cellulitis. Some red, tender spot on the arm, say. We have some cellulitis. We want to treat them with antibiotics. Keflex, is that a good start?
Yes. Still for cellulitis, and remember we're talking cellulitis here, no abscess, no pus, for a pure cellulitis. And sometimes it is worth remembering that sometimes you can miss that abscess. So if you do see some, a focal area of induration or extra tenderness there, if you have it available, a bedside ultrasound can be really helpful in those cases where you're not sure. Just make sure there's not a fluid collection under there. But for a cellulitis where there's no abscess, it's just an infection in the skin soft tissue, those are mostly always strep. If there's not pus there, if there's not a fluid collection, pus collection, then they're mostly not staph, it's mostly strep. And you can do just Keflex alone. I know some docs, I've seen them doing the Keflex and plus they do the Bactrim or the Trimethoprim Sulfa to cover for MRSA. You don't have to do that. In fact, we did a study looking exactly at that. For cellulitis, no abscess, compared cephalexin alone to cephalexin plus trimethoprim sulfa, no difference. You don't need to add it, just the cephalexin is fine.
And that's just when we have that red erythematous irritated cellulitis.
Correct.
So then when are we triggered to start thinking about adding Mrsa coverage?
If there's pus, sometimes I will do it if there's a little folliculitis type picture. Not necessarily a drainable abscess, but little tiny pustular things, because sometimes it starts as a folliculitis, which can be from staph. Again, most cellulitis, you don't see that, but if you're seeing something that looks purulent, little pimple type things in the middle of it, even if they're not big enough to drain, some of those circumstances I might think about adding it.
Okay, so I want to talk about, you mentioned Bactrim as being one of the choices for when we see a little bit of pus, we want to cover for Mrsa. Is Bactrim the best choice? Are there other choices we can consider? Because I think so many of us, maybe from even studies that you've done, are like Bactrim Keflex. We see pus, Bactrim Keflex. But is there something else we could pair with Keflex that may be equivalent or even better?
So historically, the susceptibility of MRSA to trimethoprim sulfa or Bactrim here in the US was really high. I mean, even after decades of using that antibiotic, it had still been, 98, 99% susceptible. I think we're at the point where it looks like that's changing. I mean, there are some anecdotal observations of decreasing susceptibility to sulfa among MRSA in the US. We've seen it at our own hospital. It's gone from, just recently, when I looked at just our most recent antibiogram, it's gone from like 90-something% down to like 70-something%.
Oh, wow.
Now that includes a lot of inpatients. When you look at just the outpatients, it's still kind of high 80s. But there are some places where it's going lower than that. And so in some places, you may talk to your local ID people, look at your local antibiograms if you have them, and see if you may be seeing more trimethoprim sulfa resistance, because in time I think we may be moving more to alternate things like doxycycline. Doxycycline still probably 90% or plus susceptibilities of MRSA. Clindamycin is maybe 90-95%. Again, there is some regional variability. I prefer either the trimethoprim sulfa or doxy to the Clinda, just because Clinda is more expensive, more GI side effects. So I tend to prefer the others most of the time.
So in your practice right now, are you doing Bactrim or are you starting to turn to doxy?
I am honestly just recently at the turning point of sometimes going toward doxy. Now for doxy here in beautiful sunny Southern California, we do have the phototoxicity risk at sometimes. But generally, they're both pretty safe drugs. I mean, doxy does cause some stomach upset, has the photosensitivity. So, warn people if they're working outside as a gardener or something, then you definitely want to warn them to use sunscreen, protect themselves, et cetera. But they're both pretty safe drugs. Yes, there are some rare allergic reactions to sulfa always, but generally speaking, they're pretty well tolerated.
And I mean, Clinda also sounds like a great option, but I always think of like am I going to give this person C. diff and like so many other problems, or just like horrible diarrhea plus an abscess that they have to deal with? So, okay, so doxy.
Doxy.
All right.
Sulfa, look at what's in your area if you have access to that. I know, if you're a hospital-based place, you might have those data. If you're somewhere in an urgent care, you may not really have as good an idea.
Okay, now I just have to ask this question about Keflex, because I really just feel so mean when I'm like, you've got to take it 4 times a day, every 6 hours. I even tell people to set an alarm on their phone, and it just seems so brutal. So I don't know if you can actually tell me this as an ID person, but is it okay to do 3 times a day, or does it really need to be taken 4 times a day?
A dose will last, you'll keep a therapeutic level with a dose for about 6 to 8 hours, so somewhere in there. So if you do it 3 times a day and you're going to every 8 hours, there may be a little time in there when you're maybe kind of, dipping below the therapeutic levels. Again, we're not talking about life-threatening infections here. We're talking about cellulitis, right? We're talking about skin infections. So what I do is, first of all, you may read somewhere for skin infections, you can do a lower dose of 250 of cephalexin. Don't do that. You can't overdose on cephalexin. Just give the bigger dose, right? Just give the 500 milligram.
Right.
And for most people, TID is fine. Sometimes I'll write it for QID, assuming they're going to take it TID.
Exactly.
But if they're spacing it correctly, if they're spacing it evenly throughout the 24-hour period, 500 milligrams, Q8 hours should be okay.
All right, you heard it here. But I do agree. You write it for 4 times a day, and I'm gonna guess, and I would probably be the same patient, there's a good chance they're gonna take it TID, and that's probably okay. Okay, so now you've decided to treat with these antibiotics. You are gonna write this prescription. How long, just for the average run-of-the-mill cellulitis, do we need to do the course of antibiotics for?
That is a really good question. And the big move in infectious disease in general now is to try to make the course as short as possible.
Okay.
Shorter is better. And most things, when they do the studies, they have to pick some arbitrary number. Mostly it's 10 days or it's 7 days. And that's because we have 10 fingers and there's 7 days in a week. That's really the only reason. And so for most things, for a drained abscess, for example, remember, we did a study showing that antibiotics do help cure rates be a little higher. And the antibiotics also have some secondary effects. With a drained abscess, less recurrent infections, less need for repeat incision and drainage, less infections in household contacts even. We know sometimes MRSA in particular spreads to other people. So there are benefits to doing the antibiotics for these. The old teaching was if you drained it well, you didn't have to give antibiotics. We did a study that, it's changed my practice, that it actually does show that there are some benefits. We did it for 7 days in that study. My own practice usually is to do 5. Mostly I do shorter courses. And you actually get less resistance when you do shorter courses. Because remember, the resistance is not so much from the bacteria that are in the infection, it's all the trillions of bacteria in our gut.
Right.
And so, you give somebody a 10 or 14-day course of trimethoprim sulfa, at the end of that, they are pooping out pure trimethoprim sulfa resistant E. coli. And so if you do it shorter, then in the big picture, you're going to lead to less resistance by doing those shorter courses.
Okay, so even we can lean towards 5, maybe if it's kind of big and nasty, 7, but really shouldn't be going over 7 for most cases.
Or it would be the exception that you would need to go over 7. Mostly not.
All right.
And remember, main thing is drain it. There's an abscess, got to drain it.
Okay, so let's talk about draining that abscess, because I feel like this might be one of the most controversial, very different amongst other people's practice. They do the IND, everyone can agree, get in there, break up the loculations, get the pus out. Do you pack it or do you leave it alone?
I mostly do not. There are some studies supporting that comparing, if you randomize people packing, non-packing, they do pretty much the same. Again, as long as you drain it well. There are a few exceptions that I'll pack it. So the main idea of the packing is just to keep it from closing over the top.
Sure.
And so there's some, if it's kind of a small incision, or if it's something where it looks like it's kind of sticking together and just a crust is going to form, I will sometimes pack them. You don't need to do a big, deep, really tight packing. It's really just enough to keep that skin from sticking together initially. And the one thing I never do is tell them, oh, you've got to take out the packing and then repack it. I remember, 20, 30 years ago, we do that. It's horrible. It's painful. Everybody hates it. Don't need to do it. And so if those few exceptions where I'm going to do it, I will pack it once and I tell them, look, tomorrow or the next day, just pull it out yourself at home and leave it be.
Got it.
And most of them, if you can drain it well, and if it looks like it's, open enough that it can continue draining, that is all you need to do.
Well, I just know that this is so different, even amongst the couple different hospitals that I work at. One hospital, nobody packs. The other hospital, literally everybody packs. And I don't know, I would be interesting to look at like just the outcomes of those abscesses, because I've never really, I don't think anybody studied that at our couple hospitals, but it would be interesting to see which group does better. Now, Gita Pensa couldn't be with us tonight, but we did ask her the same question, to pack or not to pack. So let's see what Gita says.
Okay, so when do I pack an abscess that I have IND'd? I know the data's been kind of all over the place about whether you need to in smaller abscesses or not. I tend to leave superficial abscesses that really don't have a big cavity inside. I do not try to wedge a teeny bit of packing in there just to pack them. Packing, I think, it's painful for the patient, and I'm not sure it does any good in those scenarios. I do tend to pack wounds that have, more than a few centimeters of a cavity inside. So if I've gotten in there and I broke up loculations and I can put my instrument in there and spread it, and I feel like there's a pretty good gap that could accommodate a solid wad of iodoform gauze, I typically will pack those. And then anything certainly like a large abscess, I'm definitely going to pack. But I guess if you ask me to pick a number, I'd say like 3 centimeters, 4 centimeters, somewhere around there is where I start to think that like, okay, I think I should probably pack this one and leave it open. But it just, when I get in there and I feel like I've gotten a lot of stuff out of here and there is a cavity, then I feel the need to fill the cavity. I'm interested in seeing what everybody else does.
So as we can tell, even just amongst the small group of faculty here, it's controversial and people have different practices. I agree with Greg. I think, honestly, sometimes if I think that I've just made a small incision, I'll just make a bigger incision to allow it to drain, because that's the big thing about packing. You just want it to drain and not close up and form another abscess.
Right.
All right, well, thank you.
The other thing, I'll sometimes tell people, just, wash it, soap and water, so it doesn't form that crust over it. If they keep kind of washing it, scrub it just a little bit, just to keep it open so it can continue to drain, then that will be helpful too, and often that will obviate the need to pack it.
Well, thank you so much. I think this is all incredibly important for our day-to-day practice, how to manage cellulitis, expert tips on abscess drainage. So let's turn to Scott to see if the audience had any thoughts on antibiotics, packing, what do you do? Let's find out.
Thanks, Britt. Yeah, you guys were pretty active in the chat. We thought it'd be a good time to pause, take a feel of the pulse here, review a little bit of what we've already learned so far in Grand Rounds. So we first went over some of our images of the evening, the Liz Franck injury. 50% of you out there said that you would get a weight-bearing film. And I find that really interesting because that was something I was classically taught for these folks. In an urgent care setting, you're not going to have CT, which is obviously more sensitive, more specific for this type of injury. So there you have it, 50-50. If you want a really great medical history story, I think Mel threw it in there in the chat. Look up the history of why the Liz Franck fracture or injury has its name. We're going back to the Napoleonic War era and some midfoot amputations. It's a pretty crazy story. We also asked you some questions about antibiotic use in the chat. So 25% of the people, just about that, are double covering for these like purulent cellulitis infections with Keflex and Bactrim. 75% are doing monotherapy here. And it's funny, I find that like depending on where you've trained, kind of that's been ingrained in you. I know when I was in med school in New York, everyone did Bactrim and Keflex for those infections. And now where I work at LA County, it's pretty much Keflex only. And then finally, we asked how many of you out there are packing these INDs that you do. And obviously there's a lot of factors that go into this, whether or not it's a big gaping area like we just heard about, or it's a small, tiny, hard to reach abscess that you're worried is gonna like pucker itself closed. And it's about 20% I don't pack, or sorry, 20% I pack, 80% I don't pack split. I know in my practice, I'm not routinely packing these. There's pretty good evidence that it just causes patients a lot of pain and discomfort. As you can imagine, having a large wad of gauze sort of tucked somewhere in your body would feel. But you know what? Depending on where it is, just know that's a tool that you have in your tool belt. We've got a really exciting next segment up for you, but before you go on, make sure to slam that subscribe button down below so you stay in tune for all of our other Grand Rounds that are coming up. And now I want to prepare you for our most exciting segment of the evening, I think. We're going to get out and see the artistic ability, not just the medical knowledge of some of these people on stage here tonight. We're going to be doing some EKG Pictionary.
I think my 8-year-old nephew could be a doctor. Look at this. Sure. Are you bored of board games?
I can't think of anything else to do. I wish I could.
If I may make a suggestion.
You haven't time to play.
Looking to spice up your next cocktail hour?
He's in love with you.
A nerve.
All right, listen.
The absolute
Forget it. It's not.
Who does he think he is?
As long as his name's
Ekg Pictionary. The most fun you'll have this evening.
The evening has been unusually stimulating.
All right, guys, it is time for some friendly competition. We're gonna play a game I like to call Ekg Pictionary. So, to do this, we have two teams. It is me and Greg Moran versus Jesse Werner and Sean Nort.
Air high five to Sean.
Greg, we got this. Okay. All right, so how this is gonna go down. Jesse and I, we're gonna draw an EKG. We get 60 seconds to do it, while our teammate guesses what the heck we're trying to draw. And we're doctors, we're not artists, so
Okay.
feel free
Speak
to
for
make fun of us.
Yeah, no, I'm feeling great about this.
Feeling good.
Yeah.
Okay, so we get 60 seconds. After that 60 seconds, Stuart is going to review with a real EKG, not our like crazy weird looking drawing, the teaching points, the pearls, and we're going to see who wins.
Stuart, you might want to use mine. It could be that good.
It could be that good.
Yeah.
We are very talented. So we're going to time it. Our first up is going to be Jesse. So Sean, you ready out there?
I'm ready.
All right, let's do this. You got 60 seconds on the clock. Pick your EKG, go.
All right, here we go, partner. You got to really think outside the box here.
Mm-hmm.
Pebble Beach.
What's he say? Oh, Pebble Beach. Okay, all right, hang on. Okay, all right.
All right.
Okay, this is science here.
Oh, okay.
Okay.
Oh.
Yep, I think.
I don't know where you're going.
Well,
all right. It's all about this. Okay,
Yeah.
so that's where we're starting. Now, let's say you did order an EKG.
10 seconds.
do I guess now? Okay, I think this is Brugada syndrome because I see, as a pharmacologist, I see salt, and this is a channelopathy, so that is a chromosome.
It went wacky. It's a wacky sodium channel.
Right, it's a channelopathy, and then of course I can see you're doing that biphasic V1, V2, V3 that I'm sure Stuart will talk about. Great job.
Thanks, Sean. I knew you would get that.
All
All right, Stuart, what do you think?
Drawing, come on.
All right, so we have one. Yeah, we have one, and this is that's brilliant, by the way. That's really
that was-
brilliant. And of course, Sean, that was brilliant. This is a pretty classic Brugada pattern here, and it comes in a lot of shapes and sizes. But it turns out that the more classic it looks, the more classic the appearance is, the closer it is to this one, the bigger the risk to the patient. And these are the patients that maybe report, a syncopal episode, and you're lucky to catch it. The next time around, they could have a sudden cardiac death. And so just to be sure we're all looking at the same thing, and it really is a pattern recognition thing. When we look at V1 here, you also see it in V2 here. It is a very classic widened QRS. It has a RSR primed appearance and this really typical downsloping, sharp downsloping appearance to the QRS as it goes into the T. It's just, you got to recognize it. Now, you're going to see patients that have this, that came in, they had an incidental ECG, it was a pre-op, or it was, they had for whatever reason they got an ECG. Not everyone with this pattern will have reason for concern. It's when the symptoms and the ECG come together that you really got to be onto this, and you really need to get a cardiology consult to make sure that, and the treatment for this is an AICD. So that's Brugada syndrome. That's the classic example. There you have it.
All right, we're going to do our next one. Ready?
All right, Britt, I'm putting
I got-
60 seconds on the clock here.
I got
You ready?
60 seconds. All right,
And
Greg, you ready?
I'm ready.
All right, let's do it.
begin.
Ooh, I get a real ECG, yeah.
It's looking great.
Greg, help me out.
Okay. Okay. What I see on the ECG tracing, it looks like every other beat has a different axis. What I think you're drawing there is an electrical alternans, which is happening because there is a pericardial effusion and the heart is swinging back and forth in that pericardial sac.
Yes!
Well done.
Electrical alternans.
You are really good.
You're a
at
good
that.
drawer. You're a good
Like,
drawer.
the way that she sort of seamlessly goes along. I had a professor that would be able to draw the cross sections of the spinal cords in the brains, and he was totally ambidextrous, and he'd go like this and like that would be done. You were kind of like that. That's really amazing. I have do I have an example? This is another example of an electrical alternans here, and it's I think it's a little bit easier to see when you get a long strip here. Here you have big and small and big and small, big and small and big and small, big and small. It's funny how it looks here, because what Greg was describing, this happens when you have something around the heart, when you have a large effusion around the heart, and it interferes with the axis. It shifts the heart within the mediastinum, and so sometimes that shift will cause the actual axis to change as it kind of shuttles back and forth, and that's why you're seeing here this kind of, why is it like, up and then down here? Well, that's all part of the same condition, the electrical alternans, and you can see it like that in different leads. So, you see something like this in a patient that has a reason to have fluid around their heart, especially if you're starting to see other clinical signs, that's a problem. They need to go to the ER, they need an echo, and that will need to be drained, and sometimes emergently if they're really getting sick. So very important thing to pick up on the ECG. Very good, very impressive. I'm blown away. Good job.
We're artists back here,
You
really.
Yeah, you're really making me feel good, Stuart. Man, I should think about another career.
Yeah, I think we chose the wrong job. Okay, so we've got another one. Jesse, Sean, you ready?
You ready,
You've
Sean?
I'm ready.
Hold on, let me get my clock. Hold on. No cheating.
No, no cheating.
And go.
We don't need to cheat. Here's another.
Give him an EKG.
All right. Here's an EKG. Okay.
Is that a delta wave? Yeah, so WPW?
Yeah.
Okay.
Woo, this is a delta sign.
All right.
And a
Greg
wave.
and I are both musicians. I thought it was actually.
Semi-quaver, something like that, yeah.
I thought it was a quarter note. That's what I thought. It was
I went Greek on you. I went Greek on you.
No, that's great.
Oh, that's great, yeah. So we have an example of a WPW here, and this is the most common thing you're going to see. This is a type A WPW, where actually you have an accessory pathway. Remember, that's the pathway that bypasses the AV node that is left-sided. And so that's the most common situation. And it generally results in this shortened PR interval, as you can see everywhere here, and this upsloping positive delta wave. And when you see this, in and of itself, again, this could be, the patient wow, you have WPW. Well, yeah, but I was there for something else. They might have had the EKG for another reason. Doesn't necessarily mean you have to do anything. Remember that the important thing about WPW is that it makes you susceptible to tachydysrhythmias. And so some patients will have an SVT with this, a very fast, narrow rhythm. That you just treat like any other fast, narrow SVT, as it turns out. Sometimes it'll cause a wide complex orthodromic pattern, and that you treat like any other wide complex tachycardia. The dilemma comes in WPW when they go into atrial fibrillation. That's a deadly combination. And so it's something to be aware of. I wouldn't talk about all the intricacies of. There's that discussion about how do you treat AFib with WPW. The short answer is get them in an ambulance, and they're going to usually, electricity is the way to go. They might need an AED. They might need electricity where you're at, if that's an option, if they're decompensating. I will mention one other thing. I mentioned that this is a type A WPW, and the type B is a little bit trickier. It actually involves a right-sided accessory pathway, and those ones they tend to have a wider QRS, and instead of a positive deflection, they have a negative delta wave that actually makes it look a little bit like a bundle branch block. And sometimes you'll get, the computer will say, oh, there's a left bundle branch block, and what you're really looking at is a type B type of WPW. And sometimes those are confused, the computer confuses them as well. So just to be aware of that, that's kind of a common foil. So obviously a lot to talk about with WPW, but you got to start with the basics, and there's your classic pattern.
All right.
We're ready for our next one. I'm going to get time so I can't cheat, but I don't cheat because, Greg, we're on fire. All right.
60 seconds on the clock. You ready?
Ready, Greg?
Ready.
Okay.
And begin.
Okay. I messed it up. Hold on.
Yeah, unfortunately, your ECG is not going to print out those intervals for you.
All right, so it looks like I'm looking like we have a lengthening PR interval. Is that what we're seeing here? Oh, nope.
Okay, 5 seconds.
Okay.
Come on, Greg.
So it looks like, all right, so we've got it just like we've got a drop beat there, and are those supposed to be the same? So this is a second degree block.
All right. Should we count it?
Oh.
It's
Just finish saying
it. It's time. We won this one. This is our
I think
point.
they might have won this one.
This is our point.
Aw,
This is our point.
Mobitz 2.
It's a Mobitz 2, so it's not lengthening. Okay.
No, sorry, I'm not that good of an artist. I screwed us.
We need a Z there, or a Z, or a Z if we're going to go for.
Oh.
Yeah. Oh yeah. Okay. Thank you. Okay. So let's see. Do we have? Does this one qualify? I guess this one qualifies. You know, there is such a. I have to say that there's such an anxiety about people distinguishing the types of blocks. Is this a type 1, or is this a type 2 Wenke-Back or a type 2 Mobitz? And it's sometimes really hard to tell, is this a type 2 or a type 3, a complete block? And we get very wrapped up on this, and it can be very tough to tell. And I think the way I would like to de-stress everyone. I would say that I just look at them as, you know, not so bad blocks and bad blocks. If the patient has a decent ventricular rate and they're looking relatively stable and you're seeing something fairly stable and repetitive on the ECG, that's not as much of a concern. If you're seeing a patient who's going too slow, getting hypotensive, that's more emergent. And so I think it's almost better just to divide them into, you know, good block and bad block, because, you know, all the bad blocks need to go on a monitor, need to have paddles put on, need to be in the emergency department, need to be under observation, might need a pacemaker. You know, anything that looks bad, whether it's third degree or second degree severe, it doesn't make a difference. And so I would put this into that category. You know, when you start dropping out beats, and you look at how slow this is, and when you start going that slow, I'm sure they ain't feeling too good. And so I think that if you don't know it's Mobitz 2 and you think that's, you know, all you have to know is there's P's without QRSs after them, and there's wide QRSs. The rate is slow as could be. You know, I calculate here, you know, it's really slow. We're to, you know, maybe 30. You know, you've got to do something about that. They're going to probably need a pacemaker. And so I think that will de-stress it a bit. It just so happens that the intervals between the PRs here are the same, and then you have a complete drop. That's Mobitz 2 for the record. But again, practically speaking, there's a block, it's too slow, and that's serious. I think that's the way I'd put it.
All right, so I'm putting up the score, and I'm pretty sad about it. Jesse, Sean 2, Britt, Greg 1, but there's still time. All right, Jesse,
All right,
ready?
Sean, let's bring it home. Let's bring it home.
We're doing it. Round and third.
Here we
And you're
go.
on the clock,
I feel good about
and
this.
Go. Oh, now you're getting a full
All right,
EKG.
all right.
You're getting fancy, girl.
Okay, all right. I really just want you to pay attention.
No talking in Pictionary.
Oh, sorry.
All right. So that's an inferior MI STEMI right there.
Woo, woo, woo. Yeah.
Whatever.
Amazing.
All right, so we have one here, a real life one. I love real life because, you know, it's just not exactly like a textbook. This one is pretty classic. And I think what I'd point out here, a couple things. For sure, everyone sees that there's ST elevations in lead 2, 3, and AVF, and those are our inferior leads. But what I think, what I was let's just be honest, what I used to be very confused about was I used to always think that I'm going to be looking for reciprocal changes somewhere over here in the precordium, and that's not the direct reciprocal leads to 2, 3, and AVF. Of course, they're 1 in AVL. And so always look at 1 in AVL for reciprocal changes, and these are nasty reciprocal changes. They do exactly what we don't want them to do. They're pronounced, and they're downsloping the ST segments as they go across, and 1 in AVL are directly reciprocal to 2, 3, and AVF. So when you have elevations in one set of leads and depressions in the exact reciprocal leads, you've got a STEMI, of course, you've got a STEMI, I'll just put it that way. And the one last thing I would say, and this I think is really relevant from, you're in an urgent care situation where you're going to be transferring the patient to an emergency department. One thing that's helpful to know is that inferior STEMIs may not do well unless they get fluids, and that's because so many of them involve a right ventricular infarction, and they involve the right ventricle. And just looking at this EKG, I suspect that's what's going on here, because I look at this and I see that there's an especially exaggerated ST segment elevation in lead 3, more than lead 2, and that points a little bit rightward. And so I suspect that this patient might have a right-sided infarction along with their inferior infarct. And the reason that's so important is that, as that patient is being stabilized, you're getting an IV in, the ambulance is coming, they might need a fluid bolus. They might need 1 or 2 liters of fluid if they're hypotensive, and that's not intuitive. We don't think of that automatically when we think of how we're going to treat a STEMI in the field. And so that's something to be aware of, that they might have a right-sided infarction. So there you have the inferior STEMI. That's great. Good job.
All right, so just a quick reminder that it's not an interior STEMI, it's an inferior STEMI.
Yes. Well, it was feeling self-conscious. It didn't want to be considered inferior, so it made itself interior.
Right, okay. But we all know it's inferior.
Inferior.
Okay. All right, Greg, we've got one last one.
We'll make this one worth 2 points. If you get this one, it'll be a tie game.
This is a tough one. I'm going to do my best. Okay.
Ready? All right, 60 seconds on the clock, and go.
Atrial fibrillation.
Yes!
Irregularly,
Atrial fibrillation.
irregular.
That was less than 10 seconds.
Yeah, under 10 seconds. That should be like triple points, I think.
That one's not worth 2 points.
Well drawn. You don't think so, Sean? Sean says no.
I'm fine with, I'm fine for him getting 2 points.
Oh, okay.
Yeah!
Okay, so for this one, atrial fibrillation, this one I think is, take note, this is juicy because this is something that I can't tell you how many times I miss this. When we think of atrial fibrillation, we think of fibrillation. We all want to see, and that's how right away, you got it, fibrillation, you're seeing that. We also like to see kind of a chaotic ventricular response to that fibrillation. No 2 RR intervals are the same, they're all different. And when you look at this ECG, to be honest with you, let's be honest for a second here. When I looked at this ECG, I think there's some symmetry here. I kind of see couplets here and couplets here. There's a regular pattern here, and that's actually misleading because if you look at the whole strip and you really actually look at these intervals, they're not completely symmetrical. And then, of course, here they do get completely unpredictable in terms of the distances between the RR intervals here. And so if that wasn't hard enough, that there do look like there's these couplets and there does look to be this symmetry, if that didn't make it hard enough, where's the fibrillation waves here? We want to see some fibrillation waves. So this is sort of like a really tricky ECG because I don't really see fibrillation waves. Now, here's the take-home point, which is that it's the irregularity of the RR intervals that is the cornerstone of AFib diagnosis, not the fibrillatory waves, which you may not see because the voltage just, the amplitude isn't there. It could be because of their body habitus. You might not see that. So you have to be aware that when you do have different intervals from and that's what the computer does when it reads this, so it kind of helps you. But if you do have different intervals that are really not at all patterned, you have to think about atrial fibrillation. This is incredibly important. I mean, clinically, this is really, really important. This patient might be susceptible to stroke, might need anticoagulation. In the clinical context, this could mean everything. Picking up AFib is not a minor thing. It's a big deal. And you'll probably see commercials for this, right? People that want to get diagnosed off their Fitbits and stuff like that because it matters. You know, it puts them at risk for stroke, among other things. So this is a tricky AFib ECG. I think it's well worth, you know, looking at these to recognize how easy it is to miss them.
All right, so that concludes our EKG Pictionary. Thank you for playing along.
Thank you, Britt. Thank you, Sean. Partners for life.
Great artist.
Yay. So now we just need to take a little break to hear a word from our sponsors, which is UC Max.
You may have heard that EMRAP has a bunch of new content in the urgent care area. And now you can toggle between whether you want to be front-facing with emergency medicine stuff or front-facing with urgent care stuff. And you just go on to the admin on your account and you can toggle between the two, and then magically the app will have that preference. Let's take a look. So here's the little button, and then you go into your account info and you go to settings, and it says urgent care emergency medicine. So if I click on emergency medicine, the app will be emergency medicine forward. And if I click on urgent care, boom, it will be urgent care forward. Yeah, it's amazing. And then you update the account settings. So this is the emergency medicine forward. See the little thing up the top there? Then you see all your emergency medicine stuff first. Now I've toggled my settings to urgent care, and look at that. Magically, now urgent care is up front and EMRAP is second. And then all the other content is down the line. This is kind of magical. And I should also say, it also affects what comes in the video tab. See down the bottom there? So if, again, you toggle to urgent care, you're going to get sort of mostly urgent care videos up front. And if you do emergency medicine, you'll get mostly emergency medicine videos up front. But remember, everybody gets everything. So, you know, don't worry about it, mate. So this is where we pay some of the bills. Don't say anything for a second. I've got questions for you in a minute. But UC Maximus went live last week. And this is our urgent care offering that we've now added to the rest of our universe. And we're super excited about it. We've been getting a lot of interaction, and it's a whole universe. It's really cool. And this Grand Rounds is just part of it. So go check it out. It's on the app. And that toggling thing is huge. So you can say which one you want to have forward, you know, EM or urgent care. So it's very cool. So now let's talk to Greg Moran here. He's triple boarded. He's EM, he's IM, he's AD. He was my boss back in the day. He's way too educated. But I got a question for you. In Florida, they had this thing called a hurricane. And now they're talking about all of these Vibrio things. Now, what I know about Vibrio is if you swallow it and you're immune suppressed, you get really septic and you die. And if you step on things, you get infection, cellulitis, necrotizing fasciitis. Why does hurricanes make this worse?
I haven't had to say a word. You explained all that very well.
Thank you.
So Vibrios live in warm water, warm salt water. So in salt water that mostly in the Gulf area where the waters are warmer, where on the Pacific coast over here where the water's colder, generally we don't really see too much here. So generally in the Gulf, around Florida, around there is where you tend to see these. They can go in concentrate in the shellfish, so you can get a gastroenteritis if you eat it, and you can get sick from it. Mostly those are self-limited gastroenteritis, and most people don't really need to treat it. It's kind of self-limited. But in people who are immunosuppressed, liver failure in particular is a big risk factor for it, but any kind of immunosuppression can put people at risk of getting sepsis from that. And during hurricanes, all of this warm, brackish water, kind of mix of salt water and fresh water, there's flooding and people are trudging through it, and often there's debris and they're getting cuts on their lower extremities and they're walking through this bacteria-infested waters, and so they get infections and they can get sick. They can get soft tissue infections that can progress to necrotizing type infections, and they can get very sick from these.
So in Florida, what they've seen is a huge increase in the number of cases. Do we need to know the difference between Volnificus and Hemolyticus, what it is, two types? Do I care?
No, no, you don't really care.
And what do I treat them with? Let's say they come in with a skin and soft tissue infection, it's looking cellulitic, maybe it's looking worse than that. Usual stuff plus things?
Yes, you're not, it's going to depend on the scenario. Most places, and most of us are not working in a place immediately post-hurricane. So when we see, necrotizing type skin soft tissue infection, this is probably not going to be on our radar. But in this type of setting, you would want to add something that would cover Vibrio. Primary treatments are going to be either doxycycline, so you can add that to your empiric treatment. Cultures, of course, are going to take a couple of days. So you can add doxycycline. Fluoroquinolones also work. So you could do either doxy, you could add ciprofloxacin, something like that.
All right, so this goes with that old adage, no patient dies without a course of doxycycline. That's what I learned from you teaching me from ID. I got some other things here. This one was from Schreiger, who wants to say that he thinks that if you IND something really well, you never need other antibiotics. Is he right or is he wrong?
He's not wrong. In our study, we did this big randomized study. Abscesses, drain in the emergency department, antibiotics, they get trimethoprim sulfa for a week or they get placebo. 86% of the people with placebo got better. Remember, most of them are going to get better. There was a higher cure rate with the antibiotic. It was 7% difference, and so not a huge difference between them. But as I mentioned before, there are other secondary benefits to it. Less recurrences, less need for repeat INDs, less infection in household members. I think when you add all those things together, it is worth doing the antibiotic. The antibiotics are cheap, cost a few bucks. And for all of these secondary benefits as well, I think the benefit outweighs the risk for these. But again, the actual cure rate is pretty low, and we're not talking about life-threatening infections here. So I wouldn't criticize somebody for not doing it if you can get a good drainage. This would be a good thing for a shared decision-making with a patient. You can say, look, we can do these antibiotics, it will have these benefits, but most people still get fine without them. It wouldn't be crazy to do it either way.
Another question, so about packing, draining. So the person, I can't remember who asked, works with the First Nations group, very high risk, lots of diabetes. They see a lot of recurrent infections, a lot of worsening of infections. Would you have a lower threshold for somebody who's like that higher risk CHF, obesity, diabetes? Would you be more likely to pack and drain those people?
Well, drainage for sure. They're going to get drained regardless.
Right.
But I think for the packing, in my mind, I don't know that would influence my packing decision. I think that would depend more on the abscess, the lesion itself. Was it something that I felt I could really drain effectively and that is going to continue to drain, or something that is big, may not, continue to drain as well? That would, at least for me, I think, be the bigger deciding factor.
All right, and now lastly, this is just with the electrical alternans that you saw. There was a really nice little discussion occurring in the chat, which is a reminder that it's not clear if electrical alternans is because you're floating in fluid, because at the end-stage CHF, patients show the same thing with no effusions. People with end-stage other cardiac disease show the same thing. So it's more than just this really nice explanation of it flopping around like that. There's more to it than that. And this is the part where I say, I'm not sure where we're going next, but now I see some silly men over here, so now I remember. We're now going to do the cooking show. I'm so excited. The EMRAP cooking show, take it away.
All right. Hello, we're back.
Hey.
Sean, are you ready?
I'm
We're gonna
ready.
get cooking?
We're going to do it. Little TXA jambalaya, just like Emerald. Bam!
Bam! We got cooking right now. No TXA for you. Let's do it today. All right, so we're talking about TXA. This little vial right here, Sean, it goes for $5,000 probably, right?
No, actually, TXA is fairly reasonably priced, which is very unusual for most of what we speak about in medicine.
Fully organic.
There you
right?
go.
Perfect
That's
ingredient to start with.
Free range TXA.
So, Sean, when I think of TXA, I hear about these studies like, HALT or, CRASH. These are studies where we're given it intravenously. We're not going to be using it that way today. So how does it work when you administer TXA IV versus we're going to put it on some other bleeding parts outside of people?
So the way that TXA works, it's actually an antifibrinolytic. And I'll just tell you real quick. Plasminogen goes to plasmin that breaks down fibrin. This is a lysine analog. It binds to that plasmin, it doesn't work anymore. So you don't get that breakdown of the clot. Works the same way when you use it topically, but you don't get those side effects. And what are those side effects? Embolism, maybe thrombus. Now that's pretty rare with even those big studies, but looking at some of the systemic things, particularly one called the MATTERS trial, which was a big military, they actually had a higher incidence of DVT and P, but we're not talking about that today. We're talking about topical.
Exactly. All the good stuff, none of the bad stuff.
That's right. Less
Perfect
filling.
nutrition. Yeah, less filling. Less filling. All right, so let's jump into the first use that we might, apply topically today. This is one that's near and dear to my heart. I grew up with like 1 billion nosebleeds. I had the Kesselbach's plexus area that was just horrible. So we're talking about Yeah, that too. I picked my nose a lot. Thanks, Mel. That's what I get. See, never misspell inferior on a slide, because that's what happens to you. You get called the nose picker online. Anyways, epistaxis here. So I love using TXA for epistaxis. Have you used a lot for that?
I have, and it really changed my practice, and I think it's changed everybody's practice, because epistaxis can be frustrating. The patients are freaked out, right?
Totally.
They've tried things at home. You can have them hold all the pressure, right? I put a little oxymetallazine in there. I have them hold, whatever. And then you come back, they release it, and it starts bleeding again. So then what are you moving on to? Some sort of packing.
Totally.
Patients hate it. ENT hates it because they pull it out, it starts bleeding again. Patients don't like it taped to it. So this is really practice changing as far as I'm concerned.
I totally agree. And as someone who grew up getting sent out of the ED with nasal packing in place, I can tell you that's super uncomfortable. It's horrible to go home with. And this is like a wonderful thing that you can give patients. So I normally work this in kind of early on in my epistaxis regimen. So whether you want to try a little bit of Afrin first, whether you want to put some epinephrine on some gauze, but it's pretty simple. I just take the gauze, roll it up, obviously using a glove if I'm doing this clinically, and dip it in the TXA and get all of that nicely absorbed. And I roll it pretty tight, and we're not going to put this saline infused gauze here, pretending that's TXA in one of our nares today, but you could take a pair of tweezers and just sort of pop it in there and work it back into the the bleeding area. And then to keep it closed, a lot of departments, urgent cares might carry this tool right here. I think this is garbage. The best thing to do with these is to just throw them out, Sean, because they don't work. They don't apply enough force, in my opinion, on the nares. And I like to take 2 tongue depressors and just tape them together like a giant clothespin, and that helps secure it. I don't know if you're experiencing
That's what. Well, most of the places I work don't have the Esther Williams nose clips to do, swimming or diving or whatever else. So that's what we do. You want to wrap those real tight though, because you do need pressure, and patients will often get tired. Like they just can't hold it long enough, or they're holding it too low or something. So I think using your tongue blades is a great idea, and I use that all the time.
Totally, and and I know there's probably been no randomized studies about combining, topical epinephrine with TXA in this thing, but do you just see at face value any problems with doing that?
No, not at all, right? So many of us, if you've been around long enough, or when I was a pharmacist, cocaine would have been perfect, right? Anesthetic, vasoconstrictive, all these things. You don't use that. Lidocaine, epi, tetracaine, very much the same. So yeah, you want to give these people some, pain relief, because that might be a little uncomfortable putting in there, but there's no downside to doing it with the Lido.
Bam! All right, let's move on to the next bleeding thing. So we have here, pretty classically, someone gets up, hits their head, falls. Like the bleeding scalp lac is sometimes a nightmare. The supravascular area, patients bleeding all over their shirt, and can be a little bit hard to get control of.
Absolutely.
This is another setting where I love, again, just taking some simple TXA on some gauze. This is not a very complex recipe here. Again, we're just dipping it in, just one stop, boom, and applying it right to the wound with some, additionally, what do you think about injecting it, subcutically, like right around the wound edge? What do you think?
So I think that's great. And I'm just going to say, so what we have here on our show is the injectable. And if you're in an urgent care, get the injectable. You can crush the tablets. I'm telling you, the pharmacist in me, it's really hard to crush. It's hard to kind of make it go into solution. You want it to be in this concentration, which is 100 milligrams per ml. Just get it, right? And stock it. So very much us in urgent care and emergency medicine, we learn from our other colleagues. Plastic surgery does this all the time.
They do.
When they are doing their surgeries, they use subcutaneous tranexamic acid to control bleeding. They have better cosmetic and better bleeding control. Let's learn from them. And yes, I think there's a great role, particularly in this guy. Look at this guy. Right, he's making salsa all over our countertop here. So he needs that bleeding.
He's spilled the ragu. We don't want that.
There you go.
We need it all in the brain. And the other thing is with the injectable solution, sometimes they like to package it in that really helpful 1940s break open the ampule packaging. The only good thing about that packaging is if you cut your finger on it, you already have the TXA in your finger. Otherwise, try to get this one if you can. Let's move on to another source of really frustrating bleeding for patients, for us to handle, and that's of course someone has a previous dental procedure, maybe they bit into something and they've got some bad gingival bleeds. So Jesse, do you have anything that you normally try first for getting these bleeds under control?
I do like to use a little TXA on gauze and have the patient just bite down on it, and sometimes I'll add a little Surgisil in there too, something else, a little topical to help with the bleeding. But I think that's a really good start. Little TXA, just have the patient bite down on it and see if you can get good control that way.
And if you want to add to your special mélange that you're going to put in there, sometimes I will put topically some lidocaine with epinephrine too. Just the epinephrine itself will vasoconstrict, numb it up a little bit topically if they're having some discomfort with it.
Those are all great ideas. You know what you can also do, and again, learning from our dental and OMFS colleagues, is mouthwash. They will do that after extractions. And you and I, when we were preparing for this, was asking, what's the difference pharmacokinetically? And I have a study that, if you're curious, I can put it in the chat, but shows if you give systemic tranexamic acid, you do not get saliva concentrations high enough to cause the antifibrinolytic activity. So you have to use it topically or use a mouthwash. So they'll do this with these people who are on anticoagulation who need an extraction, and they do it like 4 times a day, 10 mils. They just swish it around for 1 or 2 minutes, swish and spit, and there they go, they're golden. So all these combinations for these are very challenging, these bleeds sometimes.
Absolutely, and I totally agree, Jesse. The bite down on the gauze is most available, but sometimes you might actually have these little pledgets, these like ones that you find in a dental office. They absorb it really well, and they're a little bit easier sometimes for patients to bite down on because they've kind of got that like squish feeling. They're almost like a Tootsie Roll, something like that. You could pack a whole bunch in there, especially if it's like a lower bleed between the lip and the inner gingiva. It can be really, really helpful to keep them.
Yeah, I agree entirely with that.
These can be really challenging sometimes, but the mouthwash is a great technique. We've used that before. We asked Gita for some of her tips and tricks when she is in the urgent care that may or may not have tranexamic acid. Talk to her a little bit about what her thoughts were, because there have been a bunch of studies over the last few years, like nosebleeds, yes, not nosebleeds. Initially Txa when it came out was like this amazing miracle cure. You rub it on your knees and no longer you have arthritis type of thing. So let's see what she has to say for a second.
So I work in a variety of settings, and I have tranexamic acid in some places, and I don't have it in other places. So I have TXA in the ED. I have it in my fast track. I do not have it in my urgent care. I've mentioned it a couple of times, and I have not pushed particularly hard, probably because I have not found it to be this great panacea that some people seem to think it is. Perhaps it's because I tend to try it after other methods have failed, and so maybe there's some sort of selection bias because they're just tough patients. But I have had mixed success with it in, dental bleeding. Someone comes in on anticoagulants. I've had it work a couple of times. I've definitely had it not work a few times. Epistaxis. I watched a great video Jess Mason has on EMRAP. I watched that to learn how to do it. I've had it work a couple of times. I've also had it not work a few times. And that was, again, probably because I'm trying it after I did my usual, ready-made nasal rhino thing and it failed. So now I'm trying some other things to see, like, gee, can I really get this to work? So it could, again, be the selection of the patient, but I haven't used it as a first line. So I probably can't really say that I've tried it and I don't think it works. I have had patients come in who are on TXA for dysfunctional uterine bleeding. I am not in the habit of prescribing it. Typically, if someone comes to me and they've got Mrsa, I'm going to go the progesterone route. But if a gynecologist recommended it to me and said that they would really like me to start someone on it, I would not object to that. And I honestly, the place where I probably had the most success with it is in these little annoying wounds that just keep oozing. A patient on anticoagulants comes in and says, like, I nicked myself and I've had this thing oozing for 10 hours now and I can't get it to stop. I think TXA worked great in those scenarios. Just putting it on cotton pleasure or a 4x4 and applying pressure, I think that does really, really help. So do I use it? Yes. Do I think that it's the end all be all that some people do? No. But I'm very interested in hearing what everybody else has to say.
Well, there you have it, Sean. Some people like cilantro, some people don't. I don't know. It's one of my favorite recipes. I love getting TXA in there.
Well, I just think like epistaxis can be challenging, right? So you need to have a lot of, and I would say TXA, use it early, and if it doesn't work, then start moving down your pathway. That's the way my practice has changed. She brings up abnormal vaginal bleeding. Our gynecology colleagues use this all the time. Super, super safe. It's 1,300 milligrams every 8 hours for 5 days. It's an option, an alternative to progesterone, and just know that that is commonly used. In the United States, there are 650 tablets, so it's 2 650 tablets every 8 hours for 5 days.
That's perfect. And I just want to mention the video that Gita shouted out by Jess Mason, the epistaxis management one. You can check it out on EMRAP HD. Go over how to use one of these bad boys, get some TXA on it. The old like rhino rockets here can be helpful to you in your practice if you want to review that. It's an outstanding video done by Jess. And I think Mel had a question that was from the chat. What do you got for us, Mel?
Yeah, so a number of people are asking about, you said the dose that's in the injectable form, which is the form you prefer, is 100 milligrams per mil. How much are you using in these various scenarios?
That's perfect, and we have it in our textbook, Compendium. We have a whole thing that's coming out on tranexamic acid. You need to use at least 5 milliliters. That seems to be the minimal amount. So 5 mils, which is 500 milligrams, okay? So 5 mils of this, you can go over, right? You could use 10. It's not a problem.
Yeah, I normally just pop them off into a kidney basin tray. I normally don't use these little things if I'm soaking the gauze, because I just imagine some of it's going to get absorbed by the other layers of gauze. It's going to end up on the floor. It's going to end up wherever else to get that 5 ml delivered. Awesome. Any other tips for TXA from you guys? Any other things that you found fun to use it for? I think we covered a lot of the bleeding stuff, but... Yeah.
I had one more thing I was going to say that I learned from Martha and Jim Roberts, where they were treating epistaxis using a combination of, in the kidney basin, TXA, pour a little TXA in, pour a little Afrin in, or oxymetazoline, and then some Lido jelly. You make a nice little soup. You get your pledgelet in there and stuff that in the nose, and kind of all three together. And I love to do that. So I do that all the time. Then you get a little pain control too.
I love that. I do that too, and I just like stir it up very aggressively in front of the patient. We're hanging out, cooking together.
You're cooking.
Yeah, it looks great.
Cooking with gas.
You know, if you don't have TXA in your urgent care, consider it. It's super helpful. I know in a lot of cases that walk through the door of that kind of annoying bleeding, I use it. It can be a very helpful tool in your tool belt. Anything else you're cooking this weekend, Sean?
No, I think I'm just going to whip up a little TXA.
Little TXA?
Jambalaya.
All right, TXA Jambalaya. There you have it. Now hang tight. You know, one of the restaurants that you might be able to get some of this TXA Jambalaya is our new mega entertainment center, the QRS Complex. You should check it out.
I love that place.
Whether you're board certified or certified and board, whether you need relaxation or stimulation or just simple subluxation, we've got the place for you. Introducing the QRS Complex, a state-of-the-art modern entertainment plaza that's made by and for doctors. It has it all: movies, games, live music, food, shopping, and more. Gamers love the dexamethasone. Families love Madame Tussauds EKG Wax Museum, where you can take a selfie in the Circle of Willis. And no one hates music, so check out Rockuronium. Here, music lovers of all ages can enjoy the latest in immersive sound experiences using cutting-edge technology like binaural rhythm strips. Or check out the AI-powered On Dancetron. You can rave all night and not throw up. You like movies? At the center of our hedge maze, you'll find our plain film cinemas. Maybe you're into the classics like The Man from Ilcor, Cricon 2, or The Abdominal Snowman starring Katharine Hepburn. We got you. Not your speed? You like the latest action and sci-fi? We got it. Thyroid Storm with Arnold Schwarzenegger, Return of Ketorolac, and The Adventures of Ceftriaxone? No problem. We've got it all. There's something here for everyone. We've even got the world's only digital Gloria Steinem Museum.
What?
So come on down to the QRS Complex and enjoy a bigger bolus of fun than you can possibly imagine.
The QRS Complex, located right off the central line near the banks of the River Roxaban. And on Sundays, kids eat free.
All right, guys, I hope you enjoyed our little advertisement for the QRS Complex. Very much take the detour off the River Roxaban to go check it out. But before you do that, we have our last segment of the evening. It's really exciting. We're going to be talking about a bounce backs case. Let's jump into it.
Hold on, and this?
All right, welcome back. We are going to jump into a case. This is a bounce back case. Now, this isn't my case personally. This comes from the EM Bounce Back series, which is all done by our very own Mike Weinstock. So there is information here that I know that none of the faculty here know. They don't know any details of the case. It is a mystery to them. I know all. But that's not true. I actually don't know all because I can only go off the documentation that was provided by the providers that saw this patient. So you can ask all the questions you want, faculty. I will do my best to answer the questions, but I will be a little limited on what was documented. So this is a two-parter. We're going to start with the first part, part 1. You are in the urgent care. This patient comes in. He is a 34-year-old male, and he's presenting with 1 day of chest pain. Now, right off the bat, I will go ahead and give you the vitals. He's got a blood pressure of 134/70, a heart rate of 95, respiratory rate of 13. He is satting 96% on room air, and he's afebrile. What would you like to know?
Past medical history.
Yep.
Okay, past medical history. He says none. No medical problems. Otherwise healthy 34-year-old guy.
How does he describe the pain? Is it constant? Is it what is the character of his pain?
So this is a little limited. It is constant. It's a kind of dull pain. And all I know is that it's constant. That's how it's described.
Yeah, there's nothing that says that it varies with anything. It doesn't vary with, I mean, I always like to know if it varies with respiration.
It's just described as being constant. Nothing seems to make it better or worse. It's just progressively gotten worse since yesterday when it started.
Any other associated symptoms? Is he short of breath? Is he coughing? Any fever? Anything else going on?
So he does complain of a mild cough. But he says no fever, and he's not, I mean, the pain kind of feels like it takes his breath away a little bit, but he doesn't particularly feel that short of breath. A little bit of a mild cough.
Did he mention what he was up to over the past few days? Did I miss that? What's he been doing? What's anything unusual?
Nothing unusual that's in the documentation. That this pain just started a day ago, kind of out of nowhere.
And did it start suddenly, and does he have any leg pain or leg edema, anything like that?
There's nothing in the documentation about leg swelling or edema, but why do you ask?
Well, just with sort of this pleuritic component, and he's saying that...
I don't think she said there was a, I don't think there was a pleuritic component.
I thought you said
it's just gotten constant over the last 24 hours.
Yeah, I think we're trying to anchor onto something that doesn't even exist. There you go.
All right,
mistake number 1.
Yeah, there you go.
No, there doesn't seem to be any pleuritic nature to this. It's just constant, getting worse, and unfortunately there's nothing in the documentation about leg swelling.
Okay.
He wasn't given any oxygen, by the way, was he?
Nope, that is on room air in the urgent care.
Has he ever had anything like this before?
No, he has not experienced anything like this before.
Family history?
No family history of anything significant.
Meds?
He is not on any medications.
What's his body? Is he a tall, thin?
Is that going to be in the
guy?
physical exam part? Because I mean, is there anything that hits us when we walk in the room here? We look at this person.
No, he really seems to be sitting pretty comfortably. He is an average-sized human, I would say. Nothing too remarkable by just the eyeball exam.
I mean, we ask these questions because we think a tall, thin person. We might think of a dissection with like a young person with severe chest pain. We might think of things like dissection and stuff like that. So that's why we're asking what the body habitus.
Yeah. Does he localize it at all? I mean, is it the entire right chest? Is it up here? Is it down there?
Right lower is when you really kind of get to ask him. He's kind of like, I don't know, kind of like here-ish area.
What was he doing when this pain came on?
We don't know.
We don't know.
It just started. Kind of was dull and got a little bit worse over 24 hours.
Smoking or vaping?
I was going to say, he wasn't smoking any crack now, was he?
Ripping a big bong load.
So he denies any drug use. He says he's not a smoker. I mean, not everyone's the most honest human in the world, but he denies any smoking. So I guess I'm assuming that means bong rips and crack pipes.
Trauma, travel, activity when it started?
So he just noticed it happening at random. Unfortunately, there's nothing documented about travel or trauma.
And was this a repeat visit?
This is visit number 1.
This is visit
to
number
the
1.
urgent care.
Oh, Sean, you're going to wait till it's visit number 2 or 3 before
No,
we
I
actually
just wondering if he was, I just wanted to know what was done before, if he had anything.
Yeah, this is the first time
Right.
seeing any provider about
Okay.
this.
But I mean, I take it seriously, like, because he's young and it's not. It doesn't sound like a. It doesn't sound like it's not. It doesn't sound like heartburn. It sounds like there's something that's really significant here. What were you going to say, Jess?
I forget.
Oh yeah.
Yes.
Eating or vomiting prior to the pain?
No vomiting, no, it wasn't associated with anything. It just happened at random.
I remember.
Yes.
No recent illness, and has he been able to do his regular activities, exercising, going up and down stairs without any?
That's a great
Yes, yes, he's doing everything normal. He's just a little concerned that it just seems to progressively get worse and not better.
Yeah, well, I'm not letting him go. I'll tell you that much. I mean, because there's, we're in an urgent care again. We're busy. That one I'm not going to let go, even though he's young and there's nothing obviously horrible in the vital signs. I'm not comfortable with this.
So, anyone want a physical exam?
That's kind of what we're getting. Kind of what we're getting at. Yeah.
All right. What do you want to know?
Lung exam.
So the lung exam, they note that on the right lower lung there are decreased breath sounds. No crackles. That's all I got for you.
Yeah, well, that ain't good.
That's not great.
I mean, that means
there's a positive something.
Yeah, we need an X-ray. We need an ECG. I mean,
okay.
Yeah.
Is he tender in the right upper quadrant?
No abdominal tenderness.
No.
Extremities.
Sorry.
They do not document an extremity exam.
And this area of dullness, did they percuss it at all?
Is there what?
Did they percuss it at all?
They
Excuse
did
me?
For
what?
Yes, because I always do that in the ER in the urgent care. No, there's no percussion documented.
Okay. I was going to ask you about the S2, but I didn't get up the nerve.
They actually document that if
They
you want to
did?
ask
Was there
about
normal heart sounds, or was
So
there-
normal heart
Okay.
sounds, no murmur, regular,
Okay, well, that's
normal
important.
cardiac
That's
exam.
important. Yeah.
Anything else obvious on physical exam? Anything
He
else
looks-
abnormal?
Nope. If you just eyeball him, just in general, he looks like a well-appearing, comfortable 34-year-old guy.
I do sometimes ask people to take a deep breath, and as I am examining them, I want to know if anything is changing in his pain. I want him to take a big breath in. Does he stop? Is there any hesitancy? Any suggestion of pleuritic nature when he breathes in, that there might be something stopping him? That's, I think, an important thing to do on exam.
Yeah, that would be really important.
if he
Unfortunately,
didn't. Or, yeah, okay.
we did not do that here on our exam.
And it's not actually tender on the chest? And do you see any skin changes, maybe in a stripe around his
Great
chest
question. And why do you ask about that?
Well, a zoster would
Yeah.
be something that sometimes the pain can be there before you see the lesions,
Mm-hmm.
but you might see some early changes.
It would be unusual to have decreased breath sounds, but having said that, if someone is
could be
splinting due to
splinting,
pain,
yeah.
you
Yeah.
might actually, that's not a,
Right.
so.
So they don't document a skin exam, but they do say that there is no chest wall tenderness.
Right. Well, that's significant.
All right. So I know you asked for an imaging study.
Well, I think a chest X-ray and ECG would be good things to do.
Okay.
here.
So unfortunately, they did not do an EKG, but we do have a chest X-ray. How do you guys feel about this chest X-ray?
Well, it's not normal.
Yeah.
You know, that there's a flattening of the right diaphragm, and that's the area where there's
Yep.
pain.
A little blunted.
Yeah, and it's blunted. There's a suggestion that there might be some free fluid that's
Yeah.
collecting in that right hemithorax, and there's also a little bit of density that might represent some atelectasis, I'm not sure, or even possibly a pleural-based lesion, if I can imagine that. So there's a lot of things there that are concerning for me.
All right. So in the urgent care doctor read this as a right lower lobe infiltrate. And here's our diagnosis and dispo from the documentation. They diagnosed this patient with pneumonia. They sent them home with the wonderful azithromycin Z-Pak, an albuterol inhaler, and they said follow up with the ER if your pain worsens overnight. Otherwise, see your primary care doctor in 2 to 3 days if you are not better.
Well, the thing is, I don't give albuterol if they're not wheezing. And the other thing is that it's not the first thing I think about when I see a little effusion like that and a diaphragm that's not normal. I don't think about consolidative pneumonia, and so I'm concerned that this might be a missed pulmonary embolus.
Yes.
All right, any other thoughts on this Z-Pak albuterol disposition?
Are you generally prescribing only azithromycin? I mean, we're not really doing monotherapy with that anymore.
I don't know what year this was from, right? So it could be reflective of many years ago, to be fair to our colleagues, when azithromycin monotherapy would have been okay. But more recently, we would broaden that coverage to have something like doxy or something if you're thinking of community-acquired pneumonia, if that's the diagnosis.
Amoxicillin
or amoxicillin, absolutely, right. High-dose amoxicillin or something.
Yeah, I mean, if you were going to go down the, okay, I think this is pneumonia and this is how we're going to treat it outpatient, then probably Amox or Amoxiclav.
Yeah.
You know, I mean, you did mention he had some cough, right? I mean, there was maybe a little haziness there.
No fever.
But, yeah, no fever. It does sound like that diagnosis is questionable.
Questionable, yeah.
All right.
No associated symptoms.
So with this questionable diagnosis, this brings us to part 2. Now, this is the bounce back. Now we are in the ER, and the chief complaint for this patient in the ER is that he's a 34-year-old male presenting to the ED now with difficulty breathing. I will go ahead and give you those vital signs. His blood pressure now is 113/75, heart rate of 99, respiratory rate 20, satine oxygen on room air, not on any nasal cannula, is still 95%, and afebrile.
Is that really his respiratory rate? Because we're classically taught that sometimes that just gets written down. No one actually measures it. So I would want to know, was that truly measured? Is it really 20? Because if so, that's concerning.
I can only tell you what was documented.
Okay.
And it was documented as 13 before.
That's right.
Yes.
And then let's look at the blood pressure. You know, just imagine if you're in the ER and you're short of breath, okay, and you're tachycardic. I mean, these 99, these borderline, that tends to make your blood pressure go up, not you know, on the low side for gentlemen.
Yeah.
So I'm starting to get, and the stats a little bit lower before, so I'm starting to get more concerned about pulmonary embolus too.
Yes.
All right, well, I think one of the things you guys have all asked for is more history, which I wasn't able to provide for you. So I'm gonna share a little bit more history that is now documented in the ER. So here we go. He describes it still as kind of this constant, dull, right-sided chest pain, still the same. It doesn't radiate, as Jesse was asking. It's not exertional. Now, he didn't tell us what he was doing right before the pain started, but he does mention that about a week and a half ago, he strained his calf, kind of pulled a muscle playing basketball. He was never immobilized or splinted, no cast put on. He denies any lower extremity swelling, and he has no history of cancer, hemoptysis, surgery, or blood clots. So now, where do we go from here?
Oh, you could say send him to the ER. I guess
Well,
he's already there.
He's in the ER.
There. Yeah. Send him. Where do we send him?
Yeah.
Something's wrong.
CT. He needs a CTPA is what he needs, right? I mean, this is all shaping up for something very concerning because of his respiratory rate. And if you look at his previous vitals, which may not be available in ED, but he's more tachypnic, his relatively more hypoxic, and then Stuart brought up the blood pressure. So he needs a CTPA. And probably duplexes of his lower extremities.
But I wouldn't be comfortable managing this case without an ECG. You have
of course. We have to broaden this differential, of course.
That's important. We have to make sure. And that could be, that's a whole different discussion, but we have to make sure that there's no STEMI.
Sure.
But yeah, for sure, just with that X-ray looking the way it does, I mean, it has kind of like 3 or 4 features that you see in the textbook for PE. So I think you can go straight to CT scanning on something like that.
And you get a free view looking for other stuff too.
Exactly.
I mean, we've all had the experience. You do the CTPA looking for a PE, and you
Right.
find something else.
And I was going to say, and then at the end, they say, no, that's just pneumonia. And you're like, oh, at the end. But which happens sometimes, right, where it turns out. But I think this one, you've got suspicion to do your CT angio.
Okay. You asked for an EKG. We do have one of those now, and this is what it shows. What do we think about the EKG?
Well, it's not a STEMI, right? I mean, why are we doing the ECG? We're really want to make sure that we're looking. Hey, are we going to the cath lab here? Are we going to the CT suite? Are we going to So I think that's very helpful to know that it doesn't look like a STEMI.
Any other thoughts?
You want to comment on the axis? I don't know.
I mean.
So not overly impressed or thrilled by this EKG. Kind of, okay. I know you guys want the CT scan. Anybody want anything else? Are we going straight to CT scanner?
Well, what do you think?
I would go straight to CT.
Yeah,
I mean, if you want to get a D dimer, I mean, he would probably be, but like It's not going to change anything.
I don't want
If
to
his
do
D-dimer
dimer.
is low, I'm still CTing him.
Yeah.
So I think that would be a fool's errand to
Probably
get
whatever
that
you
one.
see on his plain chest X-ray, you're going to CT him.
Yeah. And now, so we could get a repeat chest X-ray and see what it would evolve, see if that effusion's bigger or anything. But it's not going to change for me.
It could be. It could be problematic, right? Like, I mean, because the signs that we're talking about are more specific than an elevated D-dimer for the diagnosis that we're worried about.
Yes.
So I think with that logic, I wouldn't do a D-dimer. Yeah.
All right.
Agree.
Well, the tech won't let you scan without labs, so here you get some labs. They got to see that creatinine,
That sounds like a
because
true
that
case.
34-year-old,
The real boss, the tech.
you just don't know what might happen.
Yeah.
And you throw on a troponin, you throw on a D-dimer. That D-dimer is really elevated, I think, to no one's surprise. This provider also gives us a little bit more in the way of imaging. What do we have here?
So you can see
It's
non-compressible.
non-compressible.
Is that popliteal?
That is popliteal.
Yeah.
Yeah.
So what are we concerned about just even based off of this?
Well,
Got a
he's
DVT.
Deep vein thrombosis as the nidus for his pulmonary embolism.
All right. So I know you guys really want this last image, so I'm just going to give it to you. And they do get a CT scan of this guy, and we have a positive circle sign on the area that we're worried about.
Because those are hard to read. I mean, they're hard to read.
Unless it's a saddle, I can't.
Yeah.
It's really satisfying to hear that from you, because me too. I always struggle. And I'm like, maybe I'm just not good enough. So it's really nice to hear someone has experienced.
Yeah, you wouldn't dismiss. I would never look at that and dismiss. I would always ask someone. I would never dismiss that based on me not seeing what I thought was. It's just.
No, I think
hard.
it's good to look. I have this tech where I scroll and follow each vessel, but I would never send them home and say, "Oh, it's good on my read."
Yeah.
No way.
Absolutely.
Right?
All right, so this was a diagnosis of PE. You guys are all so smart. You wanted to go down that road from the very beginning. You even put pleuritic in my mouth, and I didn't even say it.
If they had percussed him, it would have been me.
There was no percussion done.
No percussion. I mean, no percussion, and we didn't really talk about, like you talked about the S2, but we didn't really talk about the splitting, and you didn't get into that, and okay, we can't have everything.
Fremitus, agophony?
Yeah, agophony. Yeah.
All right, so of course this comes from EM Bounce Back. So we were really excited to hear what Mike Weinstock had to say about this case, and more like what are the teaching pearls from this. I think even you mentioned from the beginning, like that issue with anchoring right from the beginning, and it sounds like maybe we just saw a little bit of a cough, we saw a little bit of an infiltrate. Let's call it pneumonia. So let's hear what Mike Weinstock has to say about it.
This is an important case, and it's an important case because we're pretty good at diagnosing things like acute viral bronchitis, but we want to make sure that we are moving, as you've heard me say in the past, from standard of care to excellence in care, and being usually right isn't quite good enough. Now, I will say also, it's very easy with the retrospectoscope, right, to look back and say, oh, well, of course this clinician should have known that this was a pulmonary embolism. However, there were a few clues in here, and I just want to go through a few things that should help us to make sure that we don't miss rare but serious and potentially life-threatening disease. The first is the history, and of course we always talk about that, but about 90% of the time, based on the data, we're going to make a diagnosis based on history alone in the urgent care. So this free data that we get by just talking to a patient, why not get more of that, and then we can use that data to incorporate that into considerations of potential differential diagnoses. Chest pain, chest discomfort, cough, all those things, and they were documented, can be super benign, right? A viral bronchitis, but can be super serious also. So thinking about what I call the front door, back door approach, where we talk from a symptom-based approach, whether it's cough or chest pain, and asking questions to that. Onset, location, duration, exacerbators, associated symptoms, etc. And then thinking about it from a diagnosis-based perspective. It was documented that the patient had pleuritic pain. And you can certainly have that from viral pleurisy, where the parietal pleura rubs up against the visceral pleura. However, pleuritic pain is sort of like sudden onset of headache. The nidus is on us to prove that this isn't something more serious. For example, from a pulmonary embolism. Now, asking that simple question, and I call that the game-changing question, about an injury to the leg potentially could have saved this clinician and given them enough things in their data that they would have had higher suspicion in order to then look further and think about potential pulmonary embolism. And the patient did have, as was found later when the patient visited the emergency department, that the patient had had an injury to their leg. That's the thing that prompted likely the DVT that then caused the pulmonary embolism. Another clue in here is the fact that the patient has a cough but no other infectious symptoms. Exposure to ill persons, fever, productivity to the cough, chills, rhinorrhea, pharyngitis, none of those things were occurring. So lack of an alternative diagnosis, another thing that makes us concerned. And then finally, thinking about that concept of anchoring bias, where we hone in too early on a diagnosis and don't let subsequently obtained superior data to interfere with that diagnosis. That is something that we want to be aware of ourselves, but we also want to make sure that when we maybe even think likely this is from something like acute viral bronchitis, that we make sure the patient understands two very important words. And those words are diagnostic uncertainty. That's the thing that's going to allow us to make sure that the patient comes back, as they did, as it turns out, right? That they come back if things change or worsen. In this situation, giving the patient a prescription for the antibiotic, the azithromycin, even the patient wasn't convinced of the fact that he had a bacterial process, as evidenced by the fact that he didn't even fill his prescription. So, summarizing all this, making sure we gather adequate data with a history, making sure that we don't anchor too early on a diagnostic process, thinking about things that we might document which could prompt us to get some further testing. For example, the fact that the patient has pleuritic pain, or at least to explain that in a progress note why we don't think that's a pulmonary embolism. And then finally, making sure the patient understands that there's some diagnostic uncertainty, and if their symptoms change, progress, or don't resolve, that they need to return to see us in the urgent care or to go to the emergency department.
All right, so we are coming to the end of this urgent care grand rounds, and thank you all for being so active in the chat. There's been lots of good conversation, lots of amazing questions. So Scott, let's hear some of those questions from the audience. What's up?
That was an awesome case, guys. That was pretty challenging. Some people in the chat had some great comments too. Ultrasound came up a lot in the chat. You guys talked about it a lot. So I asked, how many people have access to point of care ultrasound? Not that many, 62% yes, 37% no. I know it's something that I don't have at all the sites that I work with, and I know, would you guys have jumped to that a little bit earlier, now kind of the retrospective scope in the case?
For me. For me, I wouldn't jump there before an ECG and a chest X-ray, but that's, I'm old.
I think we saw possible effusion there, right, on that X-ray, so you might have been able to
you can ultrasound that, and you can differentiate that from other things by ultrasound. Yeah, sure.
I felt like your guys' interpretation of the chest X-ray was like clearly before people like ultrasound took over. Because when I saw that, I was like, oh, there's some schmutz over there. We better ultrasound it,
Exactly.
But yeah, got all
I think ultrasound is also like, it's only as useful as you feel comfortable with it. So even if you have it, you just have to practice using it if it's not something that you have in your regular clinical practice.
Totally. We had some other questions, just cycling through all the other outlets we have for them. One was about Keflex 500 milligrams. Now, this is something I hadn't encountered in the past. Greg, maybe you have 500 milligrams Keflex GI upset as a side effect. Something you see?
I can't say I've seen a lot of GI upset with Keflex. It's a pretty safe and well-tolerated drug. Definitely Doxy. Doxy will definitely give you some upper GI upset. But and the macrolides for sure will, but not so much with Keflex, even at a 500 milligram dose.
Yeah. Sweet, love it. So no reason not to bring out the big gun of 500 as opposed to the 250.
Bring it on.
Hit that cellulitis, man.
And then we had another, like a follow-up question. I know we talked a little bit about electrical alternans before, but a little bit more about the mechanism or why we see it. And the question was, couldn't we see electrical alternans still with constrictive, like pericardopathies, like sarcoid or scleroderma, or is it really, we're really worried just about the acute large effusion when we see it?
Well, I guess I oversimplified it a bit, and the fact is, like Mel mentioned this, the fact of the matter is that there's a little more to it in terms of the mechanism, and you do see that, as Mel mentioned, in decompensated heart failure. I think that you don't look at the ECG itself in a situation like that. If someone's coming with acute cardiopulmonary symptomatology, there's a change in their condition and their symptoms, and their cardiopulmonary symptoms, cough, shortness of breath, their SATs, all that, and you see that pattern that you hadn't seen before. I mean, that has to be a trip to the ED, and they have to get an ultrasound to rule out effusion. Sure, you can have some chronic conditions where you might see that, and you do. You see that sometimes on ECGs. You're just doing a routine office ECG, and you see this alternans. Yes, you do, but that alone doesn't make you act. No.
Are they end-stage renal and on dialysis, or do they have like leukemia, lymphoma, some type of cancer? That effusion could be huge and be there forever, and their blood pressure and everything else looks great. Then it's, penetrating trauma, probably not what you're going to see in the urgent care, but if it's something that's accumulated quickly, their blood pressure is dropping, that's a real quick trip to the ER for tamponade.
Yeah, definitely. If you took the time to get that EKG and the urgent care penetrating trauma, like hats off to you.
All right. I take it back. Not penetrating trauma.
I've seen that in the trauma center before. Like we've caught that before.
The homeboy drop off to urgent care.
Oh, for sure. And speaking about things that you might encounter in the urgent care, a great question from the chat again. Like, do transcutaneous pacers really work well? If you're in the urgent care, you got one of these high-grade blocks. Patient is bradycardic, hypotensive. Like,
they're sweaty, they're hairy.
Yeah. What options do you really have? In my personal experience, I've had it work like twice of the handful of times that I've actually used it in people who weighed like 50 pounds soaking wet, and you can basically apply the pads right to the heart. I don't know, have you guys had better experiences or?
I don't think we have had better experiences, but that doesn't in general. But I don't think that means you don't try it.
Yeah.
And what are you going to do? If the rate's 30 and the pressure's low, you put that on, you try it, and it might hurt, and so you prepared to give them some analgesia.
Have somebody putting it on while you're calling 911 to take them into the emergency department.
Yeah. And you dial up.
Yes,
you dial up. You don't dial. Remember
captured.
with pacemakers for transcutaneous, you dial up. You don't start at the highest setting and then go. You dial up and until you can hopefully get some.
Go big or go home, Stuart.
Yeah, no.
Just shock them.
You set your rate and you dial up your
and dial up
the energy you're delivering as you go. See if you can get a capture.
Sweet. Mel, you had another question from the chat.
Yeah, so let's bring it back a little bit more to the urgent care. They're all very excited about all you ER docs wanting to resuscitate your patient. But they've got a question for Greg Moran.
Yes.
Ooh, Greg.
Probiotics. You're given all these antibiotics for all these different things. What is the current data on giving them some probiotics so they don't poo themselves to death?
Honestly, the true hard data on probiotics is not very robust. It isn't. It makes intuitive sense that when you're killing their gut flora that you would want to replenish them. It doesn't hurt. There's a theoretical basis to believe it might help, and so it's a reasonable thing to do, but I can't honestly say there is a lot of robust data for doing it.
I have a follow-up question for those women out there. I know we're talking about the GI flora, but what about like yeast infections with antibiotics? Because I always tell women, like, don't get the super processed sugar yogurt. Like, you got to get the probiotics, the real cultures.
This isn't Go-Gurt.
This isn't Go-Gurt. We need like Greek yogurt, the
I
good
was going to
stuff.
say, does that have to be Greek? Does that have to be like 5% milk fat?
I'm not here to support any particular yogurt, but
Kombuchas, there's all kinds of things.
Follow us next time for cooking with probiotics. We're going to be doing that segment.
But what I mean is the data still limited for that, or do you tell your female patients to eat yogurt?
Again, the data are not very good at proving that it is really beneficial in these cases, but it is a reasonable thing to do. I was always a little bothered by the fact that the probiotic things, lactobacillus, if you look at the gut flora, the antibiotics that we take are killing mostly the gram-negatives, the E. coli, those things. And there's, there's many different species. It's very complicated, the microflora in the gut. Lactobacillus is like 0.0000001% of your gut flora. And so it didn't always make intuitive sense to me, but it's so complicated and they're so interdependent that that is one of the big areas of investigation in infectious disease right now is the microflora. And we still have a lot to learn.
Jesse, you gave us a challenging case at the end of clinical images. What was the answer to it?
Which one? Oh my God.
The mystery case.
That was hours ago.
The AirPods.
These are the AirPods. The answer is mononucleosis. So this 7-year-old young man actually went with his dad to the urgent care and had a really sore throat, but absolutely refused to be swabbed. He would not allow it. And the parent, didn't want to subject him to that. So they never swabbed the child and just kind of presumptively treated him for strep. And, he developed this rash after finishing amoxicillin. Usually develops about 7 days afterwards, and that's exactly what happened. A little bit itchy, not terrible. And he then had a positive monospot test. And so if you guessed mono, you're correct. And then the thing about that, we're not sure that it's a true drug reaction. It doesn't mean that they can't take penicillins in the future, and it just goes away on its own within about 3 weeks.
All right, and we're looking through that chat.
We got it. It looks like the first person, Kevin Klug. Kevin Klug is our first.
Kevin.
Yeah, mono! Woo!
Our people call your people. We'll get you those AirPods. Promise.
And but you have to you lose them. You have to find my AirPods. That's the big thing. That's the thing.
And the teaching point is always swab. Always swab. Don't let the kid tell you no. They gotta get
in there.
Yeah, I'm always like, we're doing it. Get ready.
All right. Well, I think this is Urgent Care Grand Rounds comes to an end. Thank you to all the faculty for participating and joining us tonight. Thank you, audience, for being so active and awesome in the chat. Our next Grand Rounds is going to be Emergency Medicine Grand Rounds. And when is that?
That's going to be 11/1, the day after Halloween. It's going to be a lot of fun. And we have another one coming up after that for Urgent Care, right?
Yes, because we don't stop. It's Urgent Care Grand Rounds, which is going to be December 6th. So stay tuned.
A lot of fun, more wacky costumes, great interaction. And honestly, we're hoping to continue building our community out with you guys. It's so fun to interact with you guys all online, to be together here and really try to capture that collegiality of learning and communicating with each other, and just it's really been a special experience. And there's a whole bunch of people, not just the ones up here wearing silly costumes, having fun on stage, that make these possible. I'd like to say thanks to our entire production team.
They're amazing.
Incredible, and all the other wonderful people that make this possible. So here are their names now, and we'll see you next time. Bye, everyone.